have no disclosures to report, either in the past or in the present, regarding the contents of this activity. And really, we're going to talk about sort of the comorbidity of opioid use disorders and pain. And then I think a couple of big take-home points I want to give is that especially when it comes to acute pain management, we'll go into acute and chronic, kind of medications for opioid use disorders don't preclude the need for effective pain management. And we're going to talk about some effective strategies, right? Prevalence. So, how commonly do these coexist is really the question, that often comes up. And you can see that, chronic pain in particular is fairly closely correlated with opioid use disorders. And especially if you look at some of the more recent trials by Yang and by Serre, both from 2017, you can see that over half up to almost 2/3 of individuals with opioid use disorders meet criteria for chronic pain, right? So, so quite prevalent. And so let's look into this last citation, the Serre citation from 2017 with a magnifying lens. And this is actually really, I think, a nice study, where what the authors did is that they looked at over 5,000 adults. So they got a nice sample size, all with opioid use disorders between the years of 2006 and 2015. So about a 10-year period, and they essentially looked at and tracked all adult patients who came seeking treatment for opioid use disorders, right? And what they found again is that in almost 2/3 of those 5,000 patients, at some point, they met criteria for chronic pain. And you can see that in a majority, in 40%, right? It was in fact the chronic pain that came first. So when they obtained the history of patients coming in, the patients kind of gave the history where they developed chronic pain, they were treated for chronic pain, maybe they started taking opioids, and then at some point met criteria for opioid use disorder. In about 15%, it was unclear what came first, right? I mean, it seemed like opioid use disorder and pain were both were there at presentation, and they couldn't quite determine what came first. And in about 10%, it was the opioid use disorder came first, followed by pain. And in only about, a third, about 35.5%, was there no chronic pain history. So sort of interesting. And, and what they essentially found is that relationship can be bidirectional, but more often than not, it's the chronic pain that comes first. And so to me, really, when I think about this study, it really gets to the heart of responsible opioid prescribing in individuals with chronic pain and the importance of that. Which of course we do a separate optional module on, and we have done it a few times over the last few years where we really dig into that. Right. So now with that, going a little bit into acute pain management, we'll start with that, then we'll go to chronic pain management. But I really want to focus on acute pain management here for a bit. Again, some art, public domain art done by individuals with pain. And this one is called Overwhelm. So all details have been changed. AN, 45-year-old female, status post a shoulder surgery. History of opioid use disorder, previously treated with methadone twice. Stopped treatment both times and returned to using illicit opioids. And right before this shoulder surgery, this individual was using 0.5 gram of heroin 2 or 3 times a day, smoked, denied injection use at least recently. So now post-operatively, she's maintained on morphine continuous infusion, 4.2 milligrams per hour, plus 10 milligrams IV every 4 hours as needed for breakthrough pain. So she used this kind of as needed bolus 2 hours ago. So there's 2 more hours to go before the patient would be allowed to use it per orders, but she is requesting more pain medication. She reports her pain is 9 out of 10. She's in tears. She's reporting a lot of pain. Her vital signs are stable. And when you get to the unit, you're notified, quote, she's drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict and we don't want to worsen her addiction. So there, there we go. That's really the vignette. So let's use that, keep this in our minds as we delve into this a little bit. Some commonly held beliefs. Let's start with this. We know that in general, acute pain is frequently undertreated. It's been reported by up to 60% in inpatient setting, and this is likely higher in patients with substance use disorders, although we don't have great numbers on it, right? It's kind of hard to study. It's known that addiction is seen by healthcare professionals as, quote, primarily a social problem, requiring law enforcement rather than a health problem requiring prevention and treatment. And I know we've talked about this quite a bit throughout our many modules, the stigma that's often held by healthcare providers. And as I do this, right, I wanted to pause here for a second, maybe for bonus points. In one of the slides, I used some terminology quite on purpose today that's kind of a stigmatizing terminology. In one of the slides that we've already done. Anyone want to chat in or speak up quickly what that was? So far, did anyone catch up on some stigmatizing terminology that I included? That stigmatizing is actually going back opioid replacement therapies. I used it a couple of times. I initially had medications for opioid use disorders. And then right before doing this, I changed it to opioid replacement therapies, right? Which is sort of this old term, which maybe implies this idea that patients are kind of replacing one drug for another. So increasingly, we try not to use that term. So, for what it's worth, I just thought I would throw that in. So very good. Coming back to the materials for the day. Yes, Vanessa, I tried to be tricky today. So this is kind of how we approach it. So we as healthcare providers are not immune from stigma, right? And we really want to do everything we can to combat it. So this is the suggested approach, again, when we're working with patients with acute pain settings. Number one, accept the patient's self-reported pain. Accepting that pain behaviors can vary widely, right? And vital signs, while important, are not entirely reliable indicator of pain intensity. So just because this particular patient in our vignette had stable vital signs doesn't by itself mean that patient is not in any pain or she is faking it, right? We kind of have to respect the fact and look at the whole picture. Consider addiction, right? So which, more appropriately would be a substance use disorder versus this idea of pseudo addiction, which is this phenomenon where maybe, and admittedly a controversial phenomenon, but this idea that patient's pain is undertreated, and that's why she or he is displaying behaviors that might at first seem like substance use disorders, but if you properly treat the pain, then functioning improves, some of those behaviors go away. Versus in the case of a true substance use disorders, simply increasing the dose of the medication will not take away those behaviors, right? And functioning might continue to worsen versus physiologic dependence. And my sense was, and this vignette was based on, patients I saw during my fellowship, that this is a patient with probably some element of all three of these patients. There's clearly a substance use disorder history. There's clearly physiologic dependence on opioids, and the patient's pain is likely undertreated. And when it comes to acute pain, really the recommended approach is that if required, do not withhold opioid analgesics from people with addictions. There's really no compelling data showing that acute pain management is going to worsen the underlying substance use disorder. But if the pain is undertreated, it can lead to more cravings and potentially a risk of relapse or recurrence of illicit opioid use. So we really want to make sure we're treating this pain. And remember that a patient like the patient in our vignette already has a high tolerance, so may require higher doses of opioids than many other patients we take care of. There is also, this comes up a lot. I often will get kind of a call that the patient's already on an opioid agonist treatment, or patient's already on methadone or buprenorphine at a high dose. Shouldn't they be treating the acute pain? And the answer is no. That's really just providing treatment for that underlying baseline opioid use disorder, but it is not going to take care of acute pain. And in these patients, because they have tolerance, they're able to take kind of higher doses of opioids with relatively kind of lower risk of respiratory suppression, right? And these are the slides from PCSS I've included as reference, that if a patient shows up with opioid use disorder in an emergency department setting with acute pain management needs, how best to take care of them. And these next 3 slides are really looking at it. This little graphic on the left is a good guide. And the idea is that, as always, you want to optimize all of our non-opioid modalities, including, right, ICE, immobilization, relaxation, right, kind of RICE, NSAIDs, acetaminophen. You want to think about, local analgesics, lidocaine IV, lidocaine patches, trigger points, right? Maybe even nerve blocks, which emergency department docs and providers are starting to do more and more of, right? And only after that, you're going to start thinking of more advanced things, including subdissociative doses of ketamine, which I know anesthesia uses quite a bit. Your alpha-2 adrenergic agonists, such as clonidine or dexmedetomidine. And if those really are not enough, is when we're going to turn to opioid, sort of opioid manipulation, so to speak, for that, to achieve proper analgesia. And again, some of these things we've talked about, that patients with who are already on MOED or medications for opioid use disorder already come to us with high opioid tolerance, right? And we have to keep that in mind. So now let's look at our medications, each one methadone, buprenorphine, naltrexone, and look at best principles of acute pain management, right? So say you get a patient already on methadone, goes to a clinic, receives methadone, has an acute pain management need. The first thing we want to do is to continue the baseline methadone once you verified the dose from the home clinic. And our patients will generally readily tell us, if they're able to, what their home clinic is, because they're worried about withdrawals and they want to ensure that they can dose. So once you verified it, you can continue it. If you cannot verify the dose, say it's after hours or the weekend, it's probably safer to break up the self-reported dose in 3 or 4 times a day dosing rather than giving it all at once. It's safer, and it may actually lead to greater analgesia rather than giving the methadone all at once. And you can very carefully add in short-acting opioids if needed. Once you've exhausted all those non-opioid strategies, right? You can carefully add in short-acting opioids for breakthrough pain. You can gradually increase methadone dose. We don't want to administer buprenorphine to a patient already on methadone to avoid precipitated withdrawals. If the patients are unable to take oral dose, IV methadone is available, but remember the dosing gets tricky. You really have to reduce the dose by generally up to 2/3 and then dividing it up into 3 or 4 times a day dosing, right? So keep that in mind. And this is sort of a good way to manage patients with methadone. What if the patient comes in requiring acute pain management and they've been maintained on buprenorphine, right? Again, always start with all of our non-opioid modalities, which are highlighted very nicely in those PCSS slides. The next thing you want to do is adjust the buprenorphine dosing interval, making it more frequent, because remember, analgesia requires more frequent dosing of buprenorphine, right? So if someone's been on 12 milligrams a day at baseline, you want to think about splitting that up into 4 milligrams 3 times a day. And if that's not enough, you may also temporarily increase the dose of buprenorphine. So for example, if someone was maintained on 16 milligrams a day, maybe temporarily you change it to 8 milligrams 3 times a day. Consider IV buprenorphine if on formulary. And this is a big misunderstanding that often comes up. People will often say, well, they're on buprenorphine, so we can't get additional analgesia using other opioids. It's not true. In fact, even if someone was on buprenorphine, you can very carefully augment with short-acting opioids that have high mu-opioid receptor binding affinity to get additional analgesia. And oftentimes in the inpatient settings or the emergency department settings, if this is needed, the opioids that wind up being used are fentanyl and dilaudid. Certainly fentanyl is, of course, a big epidemic, but when used under medical setting, under proper medical management, fentanyl can be a very useful strategy because you can titrate it, right, in very accurate amounts to get adequate analgesia. It's got a high mu affinity to get that additional analgesia, and it tends to be quite short acting. And if in doubt, certainly consider an addiction medicine expert or an addiction psychiatry expert. The other piece of acute pain management is perioperative management, right? And it's important to keep in mind, again, that in general, there's this big gulf where patients fear mistreatment and providers fear deception and manipulation. So if we're the outpatient providers taking care of patients with opioid use disorders who are going to have a surgery, I think ethically it's appropriate for us to step in and try to bridge these divergent attitudes, right, between providers and patients. So the preoperative stuff is critical, right? I tell our patients that, if you're going to have a surgery, even if you think it's minor, let us know as soon as you know when you're going to have it. So we can all start talking and come up with a good plan to make sure you're not going to be in unnecessary pain and you're going to be safe, right? So as soon as the patients tell us, we get multi-party consent and we start talking and come up with a good treatment plan. The big change over the last 5 years or 6 years, right, is this idea. Before, what we used to do, I think when I was a fellow in early parts of my practice, if someone was going to have a surgery, we would stop the buprenorphine. And if they were maintained on buprenorphine, we would stop it before the surgery, with the idea that it was going to open up all of these mu opioid receptors. You would manage perioperative pain using full mu agonists, then go back on buprenorphine. However, we have moved away from that practice over the last several years. And you can see that some of these classic references are really all from 2018, right? So that's really when I started seeing a big shift in the field, where now for many procedures, we just maintain the patients, right, on buprenorphine. It's a powerful analgesic that can, as we already talked about, combine synergistically with other opioids. So we just keep the patients on buprenorphine for many procedures. And part of it is going to be the preference of the surgeon and the anesthesiologist. And that's why it's important to do that preoperative communication, right? This is the classic editorial from Anna Lamke at Stanford. Patients maintained on buprenorphine should continue buprenorphine to the perioperative period. You can perioperatively, you can use all of those strategies that were outlined in the PCSS slides, blocks, right? Epidurals with local anesthetics, if needed, things like fentanyl or dilaudid. And post-surgically, patients are already on buprenorphine, so you might adjust the dose to maximize the analgesic potentials, and that way you never have to take the patients off of buprenorphine. Naltrexone is tricky. If someone's going to have, I tell my patients to carry a medical alert card if they're on naltrexone, stating that they're on naltrexone. If it's an elective procedure, you're generally going to want the patients to stop the injectable naltrexone at least 4 weeks before the procedure. If they're taking the oral naltrexone tablet, you want them to stop the medication 3 days before the procedure. But if it's an emergent pain management need or a major surgery, the name of the game is going to be, multimodal analgesia, including things like regional analgesia, conscious sedation, or even general anesthesia in some cases, right? So this is just a little kind of a schematic. And with buprenorphine, again, increasingly, we're doing this second thing where we just continue the buprenorphine perioperatively. Some reference slides, about sort of considerations perioperatively with buprenorphine, methadone, and naltrexone, along with some medications that we use in multimodal analgesia. And you can see there are many options, right? Many non-opioid options available. So I've included these really as references, right? Again, more on multimodal pain management. When I do talks for our anesthesia residents, I go into these slides in a lot more detail. But here I've just included them as references. And in the next few minutes, I want to touch upon chronic pain management, right? Of course, we've done many, a whole echo devoted to chronic pain management in patients with opioid use disorders. So in general, this is the scenario where you want to be really careful, because a history of opioid use disorder is actually the biggest predictor, is the single biggest predictor of someone misusing prescribed opioids. So we really want to use opioid sparing approaches in patients with chronic pain who have a history of opioid use disorder. We want to use all of our non-pharmacological modalities such as acupuncture, right, such as physical therapy. We want to use all of our non-opioid medications first, and ideally use this multimodal, multidisciplinary approach. And if we are going to utilize opioids, then we want to ensure that we are monitoring, very carefully, right? Responsible opioid prescribing means using screening tools, right? Ongoing monitoring for aberrant behaviors, things like using urine drug screens, monitoring PDMP, utilizing treatment agreements. So you want to be really careful, and of course, naloxone co-prescribing, right? A little bit about, for most patients. So here's really what I want to propose in the remaining minutes, that if you're working with a patient with chronic pain and opioid use disorder, think about buprenorphine. For many of our patients, buprenorphine, winds up being a really good agent to target both the opioid use disorder as well as the chronic pain. And this is, again, based on patients at our clinic. This is a 55-year-old female. I've changed all, kind of identifying information, presenting for treatment, 12-year history of chronic pain following an ATV accident and pelvic fracture. Gradually increased doses up to over 300 morphine milligram equivalents a day. And she was displaying aberrant behaviors, buying them off the street, running out early, going to multiple doctors. She was having problems in marriage, work, relationships. She was reporting worsening depression, anxiety, and her pain wasn't getting better. She said, I have pain all over. It's worse than ever. And as we diagnosed her, in addition to chronic pain, she also at this point had opioid use disorder and very likely some element of opioid-induced hyperalgesia. So putting all that together, we started the patient on buprenorphine, 4 milligrams 3 times a day, and she had global improvements in pain. She was happier. She was functioning better at work and said, I have my life back. Right. So for many of these patients, with chronic pain and opioid use disorder, I think really consider buprenorphine. It may really be helpful. This is really what is getting at. But remember to dose the medication and do, multiple times a day dosing. A reference slides on why buprenorphine might be a good option as a frontline analgesic, certainly in this population. This was a study. It's at this point about 7 years old. But, this is it's a study out of California where they took patients with chronic pain on very, very high morphine milligram equivalents. You can see some of them had over 1,000 morphine milligram equivalents a day. They consolidated all of their opioids into just buprenorphine. And on average, all of these patients, even the patients who were on the highest MMEs, reported significant improvement in their pain. These numbers are looking at kind of the visual analog scale, right? So the higher the number, the more the pain goes from 1 to 10. So when we were switched over to buprenorphine, they reported improved pain management, and certainly things were a lot safer, right? Being on just buprenorphine as opposed to a combination of full mu agonists. Another reference slide, really just looking at the Butrans patch, which is of course a good alternative. For patients with chronic pain, it is certainly approved for that. So for most patients with chronic pain and opioid use disorder, buprenorphine is a great option. But then there is a smaller group, usually the patients with really severe pain that's not helped by buprenorphine, or patients with sort of end-of-life pain, palliative settings, cancer-related pain, where methadone may be a good option. And that's the group that I really think about methadone for their, opioid use disorder and chronic pain. And I'll just use this vignette just as to, I guess, make this more concrete or hopefully illustrate it better. So this was a 64-year-old female, came into the emergency department with dysuria, and unfortunately got diagnosed with advanced cervical carcinoma with local metastasis. And significant pain management need was identified. But there was concern that she had a 30-year history of injection drug use, right? So we talked with the palliative team, with the oncologist, and we came up with a plan where we started her on methadone at our clinic at the opioid treatment program and carefully titrated the medicine up. At the same time, our palliative team placed her on short-acting opioids for breakthrough pain. And we talked weekly, actually. We just communicated really closely because buprenorphine just was not going to be enough for her pain management needs. And we actually, I think, were able to help her through that close collaboration. And she actually, for the next 3 years or so that she was with us, she did quite well. She didn't return to illicit opioids. and felt as if, she felt as if she had dignity in that last stage, of her life. So I think about methadone, right? In that small group of people. Finally, naltrexone. If you have a patient with chronic pain and opioid use disorder, naltrexone is probably not a great option, right? And think about buprenorphine or methadone. And I will end here. It's exactly 12:30, so that's what I was aiming for.